And good morning. It is Thursday, August 27th, 2024. It says 22nd. I'm Dr. Deuk, the CEO and founder of Deuk Spine Institute. We're going to be performing spine surgery on a patient who has herniated, degenerated discs in his neck. We're fixing two discs, number 5, 6, 6, 7. He has some scoliosis as well, degenerative, with twisting of his spine. That's not causing any symptoms, but he has some pretty substantial degenerated herniated discs. Can you scroll that? All right, if you have questions during the surgery, the other way, feel free to ask me. Just type them up. So back the other way. 2, go back and stop. Scroll, stop. 2, 3, 4, 5. Let me come look at that real quick. Give me a second. I'm just going to take a peek at the MRI. 2, 3, 4, 5, 6, 7. Yeah, he's got really 2, 4, 5, 5, 6, 6, 7, but 5, 6, 6, 7 are the worst. 4, 5 is bulging a little bit. We're not treating it today. But 5, 6, 6, 7 are the worst. All right, his symptoms are primarily down his left arm, neck pain, headaches, and he's asleep. He has a tube down his throat. This is the front of his neck. First thing I have to do is touch the spine with my fingertips, which I can feel the spine right now. And I'm going to place a needle that will go into the spine from the front. Shot. 2, 3, 4, 5, 6. We need to pull on the shoulders a little bit, guys. Yeah, a little inline. Luis, I need you to get the shoulders. Shot. Okay. Shot right there. 2, 3, 4, 5, 6, 7. Nice job. Shot. Yes, perfect. Hold on. Shot. Shot. All right, AP, quickly. I'm at the front of the disc. 2, 3, 4, 5, 6, 7. AP. And I'm dead center pretty much, so I like it. Shot. All right, I need a little more pull, guys. Okay. All right, let's get an AP. Poker. I need you to, bring the flow up a little. Shot. That looks pretty darn good. Now, that's as good as it gets. We're already in the disc a little bit, so we're heading off to the left, which is good. That's the patient's left. And no. Hold on. Like I said, if you have, that's good. We're inside, Sean. Yeah. If you have questions, feel free to ask me by typing them up. I'll do my best to answer them during the surgery. Of course, the patient's surgery is the most important thing, so if it interferes, I'm not going to answer it. Shot. I just performed a discogram. One more shot. Yeah, he has very thick shoulders. 2, 3, 4, 5, 6, 7. We're at the proper level. 6, 7. The bottom disc. We're going to start by fixing 6, 7, and then we're going to go up to 5, 6. Henry,
Yes, sir.
Neck pain has many causes. Why don't we share with our audience the 30 causes of chronic neck pain that we encounter all the time?
Copy that.
I'm Dr. Deuk, CEO and founder of the Deuk Spine Institute. We're going to talk about the 30 causes of chronic neck pain. Chronic neck pain is neck pain that lasts longer than 6 weeks. There are 30 causes to chronic neck pain. The most common cause is the disc. There are 6 discs in the neck. These discs can become injured. The first disc is C2-3, next is C3-4, C4-5, C5-6, C6-7, and C7-T1. The most common disc to be injured and cause neck pain is C5-6, followed by C6-7, followed by C4-5. The other discs rarely cause pain. Discogenic pain represents 85% of chronic neck pain. Next, the facet joints cause 10% of chronic neck pain. Facet joint pain is very common in patients with neck injuries and spine injuries. Facet joint pain is usually located on the sides of the spine, either right, left, or both. Facet joint pain gets worse with rotation of your head and neck, worse with extension. The most common facet joints to be injured are C5-6, C6-7, and C4-5. C7-T1 is another common facet joint to be injured. These joints, after injury to the capsule, will develop arthritis. It is the arthritis in and around the facet joint that causes the neck pain and stiffness with movement. Deuk plasma rhizotomy is the best treatment in the world available for painful facet joints. Deuk laser disc repair is the best treatment in the world available for painful discs. Other causes of chronic neck pain include fractures, tumors, infections, and muscle spasms. These other causes represent less than 1% of chronic neck pain. Thank you for joining us for 30 causes of chronic neck pain. Welcome back, and we're going to get an x-ray view of our dilator from the front. Perfect. If you give us a little more centered view there, Jordan. Pull it towards you. Shot. Take a look at the tip of the dilator. It's just going into the disc. It's just a little to the left, which is the direction we want to head. You can see the midline. He's got some scoliosis, curvature, and you can see the dye in the disc. Show the dye, Jordan, and go back to a lateral view. There's your dye, the little black markings going out the foramen around the nerve roots, so he has tears in the back of his disc. All right, go to a lateral view. Now, we're struggling with him a little because he has such a thick neck and thick shoulders. So that makes it very hard at C6-7 on the lateral view, because those black marks are the shoulders blocking the view. And we're going to have to give a little pull down on the shoulders, everybody. All right, inline. I need inline. Good. So that's pretty good. You can see the dilators at the front of the disc. I'm going to advance it through the disc, but I need you guys to give me good shots of the x-ray. That looks really good. It's going in pretty easily, actually. Oh yeah. Shot. Jordan is working a little magic with the fluoro. We can see the back of the disc there. Show us the back of the disc, Jordan. Yep. So we're just about at the back of that disc. And I can tell you this disc is pretty badly damaged. I can feel, we're ready for the tube. I can feel how easy the dilator moves through the disc. That means the nucleus has been smashed up pretty good. So whatever he did to injure his disc, whenever it happened or whatever he's done since, has caused a lot of damage to the disc. But that said, we should be able to fix the problem with this surgery, hopefully. We've never had a failure on the cervical spine where we didn't fix the problem. You can see how small the incision is. It's just 4 millimeters. All right, I need the dilator. There it is. And there's the tube. The tube is at the front of the disc. The dilator tip is at the back. We don't want the dilator going any further. We got to keep a close eye on it. And we're going to advance the tube over the dilator through the disc. It's called the transdiscal approach. You're crossing the disc like trans-Siberian, trans-Arctic. You're going across. Now, the dilator came back a little bit. We need to advance it again, shot. But you got to just be really careful. By the way, the fluoro we're using is literally the very best in the world. There's nothing better. We source the best fluoro machines, and even with the best fluoro machine in the world, you can see that we're struggling with the picture because this guy has such a thick shoulder. Now, if I didn't feel the surgery was safe to do, I wouldn't do it. But I feel it is safe to do. All right, I think we're all the way back as far as we're going to get. I think it is safe to do, and that's why we're proceeding. I we as surgeons rely on information during the surgery. We're receiving information, these inputs, these sensory inputs, whether they're from our hands, feeling things like advancing the tube, hammering, how much resistance there is. Let's go, guys, get the floor out. Whether it's the x-ray machine giving us information, whether it's our eyes looking here at where's the shoulders, where's the neck, where's the midline, where's the Adam's apple, where's the chin. We're taking all this, as surgeons, we're taking all this sensory input in from not just the patient, but the anesthesia machines and the tools and instruments we use and the imaging, diagnostic imaging we're using in the operating room. And we're taking all those sensory inputs and we're making decisions that, you know, are important decisions made in that are based on experience and knowledge from doing these procedures for so long. All right, is the light on? Good. So we're gonna go in and we're gonna find this herniation. We are going to the back of the disc, and I know we have some questions. I will get to them, don't worry. But I wanted to get everybody up to speed. We are now at the back of the disc. Remember, we went with the tube through the disc, not harming the disc at all because the disc is like a jelly. And we're at the back of the disc where the herniations are and the inflammation is. So we're going to use our laser. You see the red stuff?
Yes,
that's inflammation. We're going to use our little laser here, which is a 0.45 millimeter diameter glass fiber, to basically vaporize. There's a herniation right there, your first one. Actually, second one, because we had one earlier, smaller. But that's a piece of herniation right there. That was sticking out, pushing on the nerves and spinal cord, stuck in the annulus, and it's scarred in. You see how it's not just popping out easy? It's like wants to stay there. And the reason for that is it's scar tissue. Because the herniation causes inflammation within the annulus, and the inflammation over time causes scar tissue. So what happens is the pieces of herniation that are causing the inflammation in the annulus, they get scarred to the annulus, and the laser is the only way to remove them. So that's why we need a laser. People say, why do you need a laser? That's why. There's some calcium, little calcification of the herniation. This is all herniation, this stuff here. The blue stuff is all pieces of herniation. Okay, we'll take the questions and then we'll go to another animation where it explains how herniated discs like this cause neck pain. Go ahead, Henry.
Alrighty, this first question coming from, forgive me if I mispronounce this name, Munya Rodzi on YouTube.
Hello, Munya Roxy. Piece of herniation right there. You guys see it? That's
Yes.
a herniation.
Yes, we do.
All right.
Munya Rodzi on YouTube asking, how do you avoid perforation of major vessels?
Well, great question. I use technique, surgical technique, to avoid perforation of major vessels. Remember, I'm a highly trained neurosurgeon, and I know how to avoid injuring things. That's what we're trained to do as surgeons. We're not just trained to go in there and operate on things and remove things. We're trained to avoid complications as well. That's why you want a highly trained neurosurgeon doing your surgery, not just some pain management doctor or orthopedic surgeon, in my opinion, who doesn't know as much about the anatomy and how to avoid complications. Now, not every neurosurgeon is equally trained. There are tremendous discrepancies in neurosurgery training. Just like there are lots of chefs out there, right? But only a few of them are really, really good. And they know how to make really nice food that you enjoy eating. And those are the very popular restaurants, I believe. Whereas there's a lot of really bad chefs who don't cook very well, and you don't want to eat their food. So surgeons are the same way. There's tons of bad surgeons who do bad and they perforate vessels and cause complications. And there are a few incredibly good surgeons who are the best in the world. Deuk Spine Institute has the very best surgeons in the world for doing spine surgery, any type of spine surgery that involves degenerative problems. That's disc problems, stenosis, facet disease, not spine tumors, not infections of the spine. We don't do that, but we do degenerative conditions and deformity, and we have literally the best techniques and the best surgeons in the world for doing it. So, how do we avoid injuring the blood vessels? Number one, we know where they are. Number two, we push them out of the way. I push it out of the way with my hand. I displace them. It's called displacement. So I'm using my fingers to displace them.
No current questions, but we do have a comment coming from a patient from Twitter saying that they are 4 weeks post-op of their DLDR, feeling great. Maximus discus reparatus.
Thank you so much. It's so good to hear from you, and I really appreciate the feedback. We have so many people saying, we see testimonials the day after surgery, but what about a year later? And I always say, well, we don't call our patients up and bother them and ask them for a testimonial a year later. So generally they do really well, and we don't hear from them ever again, but it's good to hear from you, and I appreciate you being here. All right, so just to tell you where we are at the back of the disc. And all this white stuff here is pretty much herniation and scar tissue, both. It's a combination, because at first there's a herniation, and then over time inflammation comes and your body attacks the herniation. So Henry, let's show everyone how a herniated disc, which is the start of all disc injuries, is a disc bulge, disc herniation. How does that cause so much pain in the neck? What's the mechanism by which that happens?
Copy that.
Disc injuries start with an annular tear. Damaged nucleus pulposus herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website at www.deukspine.com or call us at 1-800-FIX-MY-NECK 349-6963.
I wish we had lots of money. Okay, welcome back. So you can see from our video that this is very important, folks. 85% of all chronic neck pain that you have for more than 6 weeks, it comes from that exact video you just watched, which is called a annular tear with inflammation. And the problem is that 99.999, there's another herniation by the way, 99.99% of doctors do not know that. So if you go to your doctor with neck pain, they're not going to know the disc is the cause, because we discovered that at Deuk Spine, and getting the word out, it's not like doctors just accept whatever you tell them. They don't believe you. There's skepticism, and I think that there's such a thing as healthy skepticism. But then they should really follow up. But in the meantime, Deuk Spine offers treatments for the most common cause of neck pain, which is the herniated disc. And it's not the herniation by itself that causes pain. And it's most certainly not the herniation pushing on your nerves that cause pain in your neck, okay? Neck pain comes from the actual inflammation in the back of the disc. Now, even if you didn't have the nerves or spinal cord there, the big nerve roots, you would still have that pain, because the pain is coming from the back of the disc, not from the nerves behind the disc. If the nerves behind the disc get affected by the herniation inflammation or by pressure from the herniation, then you get what's called radiculopathy or radiculitis. Radiculitis is inflammation of the nerve root, and the symptoms are typically pain from the neck down into the shoulder and arm. That's radiculitis, or inflammation from the back of the disc getting on the dura or covering of the nerve root. By the way, these are all pieces of herniation. So far we've taken out about 12. Every one of these is another piece of herniation. You can see the yellow color is calcium. It's calcification and scar tissue, and that's why it doesn't float out. It doesn't float out nicely and easily because they're heavy. They're heavy because of the metal. Metal is calcium. Calcium is a metal. It's like iron, it's a metal. So metal is dense and it's heavy, and that's why some of these pieces are not just floating out nice and easy. they're taking their sweet old time. All right, I know we have another question, which I'll be happy to answer in just a moment, but we are in the foramen right here. That is the neural foramen, and you can see there's a little bone spur right there. I'm zapping with the laser, kind of opening things up. Remember, the laser is 0.5 millimeter wide. So we're going to get back to that in a moment, but there's still lots of herniation here that I got to deal with. So I'll take the question, and then we'll show you how we fix these herniated discs in the neck.
Yes, exactly. This next question coming from the patient on Twitter asking, after a large herniation is removed with the DLDR, will the annular tear heal on its own? And
Yes.
did the calcified herniation prevent it from healing on its own?
Yes, great question. So the answer is yes. When we do the DLDR right here, the annulus will then heal because we're removing this junk right here. See this white stuff? It's literally keeping your body from healing the annulus and closing it off. And your annulus and body are trying to heal, but they cannot because this thing is stuck here. It's like somebody putting their foot in your door. You're trying to close your front door, but you can't because their foot's in the way. You've got to get rid of the foot to close the door. All right? And the body has to get rid of this herniation to seal the annular tear. And that's what we're doing. It's called a debridement. We're cleaning up the annular tear. We're cleaning up the herniation. This is the herniation right here, sitting in the tear. So, Luis, I really like the optics on this new camera.
Still searching. I'm gonna keep searching. Yeah. We have one more week with it.
Well, yeah, unfortunately. We're just talking about the new camera system. We've been using the same camera system, which is a high definition camera, at Deuk Spine for 18 years, since we started 18 years ago. And it's worked really well, but this new system has a little bit more visibility. I like it. It's really nice. But the problem is it's $500,000. And $500,000 for a few cameras, and you know, that's it. It's crazy. That's why healthcare is so expensive, is you have all these companies, they want big money for whatever they want to give you to use. The problem is there's no big money to pay for it with. So we have to borrow money, or we get our money from insurance payments and patients payments, and our patients would have to pay for it. And I don't like the idea of asking my patients to pay more so we can get better equipment, unfortunately. Anyway, we're just talking about the system, but it's beautiful. I wish I had it, but it's expensive. And yeah, it is, whatever it is, it's unfortunate. I would love to be able to use this in the future, but the company is loaning it to us right now, and they've lent it to us for a few weeks. They want us to buy it, but honestly, we just can't afford it right now. So we will take the questions.
Yes. This next question coming from Munya Radzi once more on YouTube. Asking, sorry, I didn't get your response on avoiding vital structures when you introduce your initial needle to the disc.
Yeah, I think I gave my response. If you go back and rewind, you'll hear it. It's through displacement of the vital structures with my fingers. Displacement. That's how. All right, a lot of scar tissue here. And you asked about a calcified disc. This is calcium right here. So this disc herniation is partially calcified, and you can see the laser does a great job of removing it. We don't have any problem removing it. Once it's removed from the annular tear, then the disc will heal on its own, pain-free, no pain at all, and the pain is 100% gone that the patient had in their neck. As far as the arm pain, it goes away too, because we're getting rid of the source of inflammation. The nerve root itself is right behind this right here. It's about 3 millimeters away from this, maybe 5 millimeters away. Probably 3 to 5. Just underneath this herniation is the nerve root. And the nerve root goes from your neck down your arm. And that's what is affected by the herniation. But everybody thinks it's pressure on the nerve root by the herniation that causes symptoms, but it's not. It's inflammation of the nerve root by the annulus that's inflamed. That's what causes the symptoms. So you got to get rid of the inflammation here. You can see all the evidence of inflammation. There's a herniation right there. Look at that. Oh, it just came out where it was sitting on the nerve. Isn't that incredible?
Yes, sir. Saw
Yeah,
that.
there's no other surgery in the world that does this. This is very special. You guys are watching history in spine surgery. This surgery will replace all of the fusion surgeries and artificial disc surgeries of the future. I mean, about 95% of them. There's still going to be a need for a couple, you know, but not the vast majority, not the millions that are being done every year. All right, got another piece of herniation right there. That thing is humongous. I don't know how I'm going to get it out. We're going to have to break it up into little pieces. We call this bisecting it or bivalving it. By cutting it in half with the laser or breaking it into smaller pieces, I can take the smaller pieces out of the tube. Remember, everything has to come out of the tube. All right, any questions?
No current questions. So in the meantime, why don't we show the audience on how this surgery is performed?
I think that's a great idea, Henry. Thank you.
Perfect.
Meanwhile, I'll whittle down this herniation.
Copy that.
Disc injuries is a common cause of chronic neck pain. The inflamed annular tear causes neck pain. A 4 millimeter skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes herniated disc fragments and debrides the posterior annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website at www.deukspine.com or call us at 1-800-FIX-MY-NECK 349-6963.
Welcome back, and you can see how the Deuk laser disc repair works. But I just pulled out this big piece of herniation from the tube, from the back of the disc. Look at the size of this thing. It's actually about 8 millimeters long. Looks like a little asteroid. That's what herniations really look like. And that's people that have a herniated disc, they don't have one piece. They have about 30 pieces. They're not all that big. That's a big one for cervical. But in the lumbar spine, they're all pretty much that big. There's a little bit of bleeding in the back of the disc. What's that from? Because there's so much inflammation back there. You get all these new blood vessels growing. You take the herniation piece out. It's like uncorking a bottle of wine. You get the wine spilling out. Okay? Anyway, yeah, great. So let's keep going. Any questions?
At this moment, no current questions.
So we've talked about the 30 causes of chronic neck pain.
Correct.
We've talked about the disc, which is the #1 cause with what's called discogenic neck pain. 85% of neck pain is discogenic. And then we also have the treatment, the Deuk laser disc repair, which we just showed you guys.
Correct.
How that works. And the next thing I'd like to talk about is the second most common cause of neck pain. Oh, there's another herniation right there. You guys see that?
Yes, we do.
Just another piece coming up. So that's about 25 pieces so far we've taken out. And you can see the calcium on it. You can see the blue dye because, there we go. Bye-bye. And there's the back of the disc, and the spinal cord is down there. There's probably a little bit of scar tissue right there in front of the spinal cord, herniation, staining blue. I'm just going to zap it down. But all that herniation that was back here is pretty much gone now. You guys see the empty cavity? We're almost done with this disc. Now you may say, well, why don't I see bleeding? There is blood in the water, believe it or not. There's little blood cells. If I were to turn off the irrigation, you'd see it. So that's why the irrigation is so important. There it is. You guys see it?
Yes, we do.
All right, so we have to always irrigate with this surgery. Irrigation is a liquid. We use cold saline. I've shown you all my tricks and secrets, guys, and yet surgeons still don't do the surgery. Why? Because #1, it's very hard to learn how to do it on your own. #2, the equipment we had to buy to do this surgery was, you know, probably $2 or $3 million minimum to start, you know. And then, and you got to pay for it yourself out of your own pocket. The government doesn't help you. Banks don't help you. They don't want to give money to anybody. Too high risk. So we got lucky. We started 18 years ago. And at that time, the banks were willing to loan us money. I had to put my house on mortgage and borrow money and eventually pay it off. But it's not easy to start a business like this for patients. You know, we did it all for the patients so they can get better care. We're the only place in the United States that does this surgery because we pioneered it. We've been trying to teach other surgeons, but unfortunately, I'm not aware of any other right now in the United States doing exactly what I'm doing. Now, they do endoscopic surgery, they do disc surgery. You know, this is standard of care kind of stuff, but to do exactly what we do with the laser is very rare. You won't find too many people that do it. Now, I know they're doing it over in India. The surgeons over there send me pictures all the time and tell me, oh yeah, we're doing the Deuk laser disc repair. It works so well. But the truth is, unfortunately, surgeons make a lot more money doing fusion. So there's a big herniation right there. I'm going to try to grab it out. We're probably at about 28 pieces of herniation on this disc at 6-7 that we've already taken out. If I can get this guy, maybe like 29. There it is. You guys see that?
Yes, we do.
So just got that out. That's a nice one. Luis, I gave you a lot of nice ones today. Any questions?
Yes, we have a question coming from Munya Radzi once more on YouTube asking, how different is this from radio frequency ablation?
Oh, well, that's like asking how different is a Ferrari from a horse. Two totally different things. Radio frequency ablation is basically sticking a needle in the back of someone's spine to kill pain nerves going to their joints, their painful joints. That's not what we're doing. We're going in the front and we're dealing with a disc. Radio frequency ablation is used on joints like facet joints or the SI joint. It's not used on discs. You never use radio frequency ablation on a disc. The disc itself requires spine surgery. And unfortunately, there's a lot of pain management doctors trying to do spine surgery today. They shouldn't be. They're not trained to do it. Goes back to someone else's comment earlier about how do you avoid the blood vessels and the other structures that you don't want to harm. That's because I was trained to be a surgeon. These surgeons are trained how to avoid them. We open people up in our training. We see where everything is. We learn how to avoid injuring things. At least we're supposed to. Not all surgeons are. But that said, RFA, radiofrequency ablation, is a pain procedure done in the back of the spine to the facet joint and SI joint, whereas the disc surgery is done in the front of the spine, typically in the neck, and it's just very different. Henry, maybe you can help us, Henry. Why
Yes.
don't we show the audience the difference in the cervical spine between disc problems and facet problems? We've already shown you how the disc causes pain. Now let's show the audience how the facet joint causes pain.
Copy.
Since that was a great introduction from that person.
Yes, sir. Copy that.
All right, welcome back. You can see that the facet joints are located in the back of the spine, and they get injured at the same time the disc does. They do get arthritis from the injury over time, and they can become painful. And you can see from the video, those pain signals travel up to the brain via these little nerves. They're called the medial branch of the dorsal ramus. And that is the target of the RFA procedure, is the medial branch of the dorsal ramus. So when you go in and you use the RFA needle, you zap those nerves. But RFA doesn't work well And when it does work, it doesn't last. Patients always have to come back and get it done again. So Deuk Spine Institute developed a permanent treatment, and it's called the Deuk plasma rhizotomy. It fixes that facet pain permanently, so you don't have to keep coming back. You get it done and you're done. All right? Let's show the audience the Deuk plasma rhizotomy for the cervical spine.
Copy that.
The alternative to RFA, the better alternative. Meanwhile, I'm working on my last piece of disc herniation in this foramen here. You can see it jiggling around. All right, that's it. I'm gonna go check the other side. There's another piece again. Lots of herniation, I told you that. I could feel it when I put that tube in. But go ahead and play the animation on the Deuk plasma rhizotomy cervical for cervical facet pain. And then we're gonna meanwhile finish this disc up and move on to the next one.
Copy that.
Facet joint injury is a common cause of chronic neck pain. The inflamed facet capsule tear generates pain signals. The best treatment for facet joint pain is the Deuk plasma rhizotomy. The inflamed facet joint pain nerves are destroyed. The advantages with the Deuk plasma rhizotomy is that it's an outpatient procedure that takes 30 minutes to complete, very minimal bleeding and pain after the surgery with immediate recovery and return to work the next day, as well as a 99% success rate and permanent pain relief with a single treatment. For more details, please visit our website at www.deukspine.com or call us at 1-800-FIX-MY-NECK 349-6963.
I just can't get it. All right, we're trying to pull out these pieces of herniation. They're big, they're scarred up, they're very white with scar tissue. They're dense, they don't want to float out, they don't want to come out. So I gotta chop them into pieces with a laser. And then when they're chopped up, they will come up and out. That's pretty standard surgical technique. We do that for brain tumors. We do it for lots of mass lesions, where we just chop things up and then take the small pieces out. All right, any questions?
Yes. This next question coming from a patient on Twitter once more, asking, can Dr. Deuk talk about the trauma difference to muscles, etc., when comparing DLDR versus disc replacement versus ACDF, especially in recovery speed for patients?
Yeah, sure. So the question is, somebody has a cervical disc herniation that's symptomatic, they need it fixed. What's the difference between the surgical techniques available to treat it? The most common surgery done is called ACDF, anterior cervical discectomy and fusion. And in that procedure, which is the surgery I was taught mostly as a resident when I did my training, and it's taught all over the world, is to go in the front of your neck, make a big cut, go down to the spine, and take the whole disc out, not just the little piece in the back, the entire disc. And once the disc is out, you put a cage in there or a piece of bone, and you fuse the bones together, and the patient will lose the movement of those bones. They won't move anymore. And you can put a plate in there to hold the bones together while the fusion is happening. Remember, fusion doesn't happen in the operating room, it happens after surgery. Now the alternative that came up is called artificial disc, and instead of fusing the bones, you go in and you put a metal disc, metal and plastic disc that allows movement. I've done many of those too in my career. Those are the two most common treatments for herniated disc in the neck. Now, the Koreans invented a new technique where you go, these are South Koreans, of course, you go through the front, just like you do with ACDF, but instead you make a small little cut in the skin, and you bring in some tubes, and then you go to the back of the disc where the actual herniation is. You leave the whole front of the disc alone, and you just fix the back where the problem is. And so that's who I learned from after my training at UF in Gainesville. I went overseas and I learned from the pioneer, Dr. Sang-Ho Lee, who developed the technique and the instruments to do it, okay? He taught me how to do the surgery, along with Dr. Gun Choi, his assistant. So the advantage of their technique was that it was minimally invasive. There was no big incision. You didn't have to cut the muscles in the neck. And if you want to know about muscle cutting in the neck, just look at our comparison video, which we have. It's a comparison video on the comparison playlist, and you can see I need about 3 more minutes on this disc, Dr. B. Every time I think I'm done, I find more herniations. So I must be at about 40 herniations now. And they're just so dense, they don't float out. So I have to literally sit here and zap them. You see all the gold color, that's all calcium. They don't want to come up. So you got to make them light enough to float up, or aerodynamic enough to float up. Anyway, there's another big piece. I'm going to try to grab that one out. So the Koreans developed this technique where they didn't have to open your neck up. They just kind of went in like I am right now with a 4mm incision and just removed the herniation. But they use these grabbers, and these grabbers, to be honest, they suck. They don't work. You need the laser. So I'm the one who brought the laser in, and specifically the straight firing laser, and started doing straight fire laser, which is what this is. It's not a side firing, it's a straight firing. There's 2 types of laser, side and straight. The side doesn't work for this application. I've tried it, I don't like it, it doesn't work. So I pioneered this technique with a straight fire laser and basically published it 13 years ago, 12 and 13 years ago, 2012, 2013 in PubMed. And also I've published it at many meetings, at scientific meetings, neurosurgery meetings around the world. And so we're the pioneers at doing this technique, okay? The endoscopic is Dr. Sang-Ho Lee, but the endoscopic laser debridement of the annular tear is Deuk Spine, it's me, and my son Arias. So we're the ones who pioneered this. So this treatment is far less invasive. There's no cutting your skin wide. There's no cutting through your platysma muscle, which you have with ACDF and artificial disc. With ACDF and artificial disc, they crank on your esophagus. Basically, they push your swallowing tube during the surgery. They damage it. And your vocal cord nerve, called the recurrent laryngeal nerve, gets damaged often. Sympathetic trunk gets damaged often. The longus colli muscles get peeled off your spine. They get damaged permanently. There's a lot of muscle damage, both skeletal and smooth. The esophagus, the skeletal muscles, they're cut, they're damaged by retraction and bovine and cutting. None of that happens in this surgery. We don't do any of that. So this is a much less traumatic type surgery. We're not doing any trauma at all inside the body. We just cut the skin, that's the only trauma. Whereas the other treatments, ACDF and artificial disc, the whole surgery is traumatic. And that's why people suffer so much after those surgeries. They get a lot of scar tissue, they get a lot of complications. The complication rate for ACDF is 50%. The complication rate for this surgery is 0. We've had 0 complications in 18 years. So if you want a complication, go get an ACDF. If you want a surgery that doesn't have complications, you get this surgery, okay? You want complications, you go get an artificial disc put in your neck. Artificial disc complication rate is 25%, supposedly. I don't really believe that. That's what the artificial disc people want you to believe, but I don't think they're being honest about it. think the complication rate is much higher. But the industry controls the information, and that's why they're just trying to promote their products, okay? We don't have a product to promote. We're not trying to sell a product. We don't have a cage or plate or bone graft or anything. I'm just about done, 30 seconds. I've gotten rid of every piece of herniation back here. I don't see any more side to side. I'm very happy.
Lights on, please.
We're done. We got to move on and do the next disc though. So we got one more. You can see all the little pieces of disc herniation on the skin. Oh, here. Look at that right there. You guys see that?
Yes, we do.
Look at all those little pieces. So, I mean, we got 50 pieces maybe just right here. All these are, each of these is a piece. Each of these is a piece of herniation. But you see, herniation is not one thing. It's many herniation. This here is kind of sterile solution. It's betadine, developed by NASA just down the street here. We are in the Space Coast of Florida, in case you didn't know. We're about 15 minutes from NASA. And betadine was developed to basically sanitize against viruses, bacteria, and protozoans that could be coming from space. Space could have some nasties out there. And the United States government didn't want to bring back any nasties, right? You've all seen Alien. Not that betadine would have worked on the alien, right? Okay, any questions?
Yes, we have a question from Michael.
Everybody get ready. We're going to be moving up north. Michael.
On YouTube, yes.
I wonder if it's the Michael I know.
The Michael GF on YouTube. I don't know if that rings a bell, but
No,
it's
a different Michael.
No worries. They on YouTube asking, thank you for all your hard work in pioneering this technique, Dr. Deuk.
You're welcome.
Why do other surgeons not recognize that cleaning out the annular tear will allow it to heal?
That's a great question. I always say the same two things, arrogance and ignorance. You know, a lot of times ignorance comes from arrogance, but it can also come from lack of access to information, right? And so if you don't know the technique exists, then, you know, it's not real, huh? No, I think we're okay. We're going to be moving up north, guys. I just need to focus for a minute. But the answer is, I know spine surgeons very well. I'm a neurosurgeon. I've known them all my career. I've known hundreds of them. And I can tell you from interacting with them that it's either going to be they just don't even know this procedure is out there, or they know about it, but they don't like the fact they didn't develop it that I did. Or, you know, the truth is, financially, I get paid 10% for the surgery what I get for fusion and artificial disc. You make more money doing more invasive spine surgery, okay? I made a lot of money in my early career before I knew about this surgery, before I pioneered it. I made a lot of money doing fusions and artificial disc, a lot. That's where I made all my money. I don't make money now doing this because I get so much less. So there's a huge financial disincentive for the surgeon to recommend the surgery to a patient or even learn about the surgery, because you're going to get paid such little money. You're not going to make much money at all. So surgeons, you know, they want to make money. They've put a lot of time into their education, and they want to get paid for it. So they're not going to do a procedure that doesn't pay. Look at pain management doctors. Pain management doctors are the opposite. They were trained to do shots like epidurals, right? But now they want to do surgery. They're trying to do surgery because surgery pays more. So you could see the incentivization of doctors to do expensive procedures that pay them more. And that's the whole situation. That's what's happening. It's not about patient care anymore. It's about profitability. And it's unfortunate. It's a broken system that we work in. And a lot of it's because of the insurance companies that are taking all the money out of healthcare, putting it in, you know, their pockets or their subsidiary pockets. They're basically embezzling all the money that patients pay for their medical care away from doctors and hospitals, and into their pockets. All right, Jordan, we need a true AP. I mean, you can see the curvature there, guys, of the spine. There's like an S shape, but I gotta get as much AP as possible because I'm about to enter the front of the disc and I want to be in the middle. That's not helping. All right, try to get me a true AP. That looks pretty good. We're just about there. I think that's worse. Shot. I think that's pretty damn good. It's good enough for government work, they say. I got to move a little bit to the patient's left to be in the middle. You want to start when you enter the front of the disc, you want to be in the middle. Shot. Or as close to the middle as possible. That's perfect. So let's go back to a lateral view. Remember, you're using information from these machines to help see through the patient, and I'm using the spine, the bones of the spine, to guide me. And that's standard stuff for spine surgery. We all use the bones. But it's how you use the bones that's important. Shot. Which part of the bone you're using. Because if you use the wrong part of the bone, you get bad information. 2, 3, 4, 5, 6. Everyone agree? 5, 6. AP. All right, so we're in the front of the 5-6 disc. That's exactly where we want to be. I like the lateral view. I'm right over the center of the front on the lateral view, but I need to make sure the AP view didn't change. AP is front back. So it changed a little bit. You can see I'm slightly to the patient's left. I got to come back to his right, just a smidgen. Shot. I think that's pretty good. Shot. All right. I like that. I like that. Let's go ahead and go with that, but let's go back to a lateral. Now you can see the curvature of that spine, huh? It's like kind of like a swan neck. All right, we are definitely in good position on the lateral view, good position on the AP view. We're going to enter the disc. Shot. And I'm passing through the anterior annular ring, through the fibers. We're going to get to the middle. We're going to do a discogram. Shot. That's very nice. I got to clean out the junk that may have climbed inside the front. Shot. Any questions?
Yes, we have
Shot.
This is a comment leading towards a question
Shot.
from Charlie on YouTube.
Shot.
Comment being, it boggles my mind that more surgeons don't want to learn this endoscopic approach. After researching ACDF, I'm very concerned about all the collateral damage potential that you just mentioned.
Yeah.
Question, for cervical spine disc problems, how long is it safe to try and
Shot.
delay surgery in terms of symptoms of one's experiences? What symptoms are alarm bells for sooner rather than later?
Huh? Yeah. Yeah, so great question. The question is, I've got a herniated disc, and I know I need to get it fixed, but how long can I put it off for? And the answer is quite simple. There's 3 things that a herniated disc in the neck cause. One is pain, another is spinal cord dysfunction, and another is nerve root dysfunction. So if all you have is pain, like headaches, neck pain, cervical brachial pain, cervical radicular pain down your arm, you can wait as long as you want. If you have spinal cord dysfunction, which is pressure on the spinal cord causing balance problems, causing clumsiness of your hands, dropping things, numbness, tingling in your hand, shot, then, bladder control issues, then you shouldn't wait. You should get it done right away. On the other hand, if you have radiculopathy, which is nerve damage, shot on your nerves, nerve roots that leave the spine out of the back of the disc, then you should have, I can't see that well. We got to do a little something here, guys. Shot. That's better. That's good. Shot. Almost done. I just need 30 seconds more of your cooperation. Shot. So I got to get this tube through the disc without biopsying the disc. All right, so to finish the answer, pain, you can wait. nerve damage, you cannot. Man, the tube keeps coming backwards. You see that? I get the tube forward and then it gets pushed back by the inflammation in the disc. Shot? Shot? All right, we're there. We should be there. I feel it. I can feel the lip of the bone spurs in the back of the disc. All right. Did I answer all the questions?
I believe so. We do have a few more questions.
Well, before we go there, have we shown the Deuk plasma rhizotomy for facets?
Yes. Yes, we have.
Yeah.
We have shown pretty much all the animations.
All right. Let's show the Deuk laser disc repair animation one more time
Not a problem.
for neck herniation, cervical herniation, just so everybody can be refreshed.
Of course. Of course. Not a problem.
Meanwhile, we'll get started on this last disc with 5-6, and we'll take your questions in a moment. Feel free to type them up.
Disc injuries is a common cause of chronic neck pain. The inflamed annular tear causes neck pain. A 4mm skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes herniated disc fragments and debrides the posterior annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website at www.deukspine.com or call us at 1-800-FIX-MY-NECK 349-6963.
Well, you saw from our video that it's inflammation in the back of the disc that causes all the pain. Here is that inflammation. We are at the back of number 5-6. Look at all the red and pink. That is supposed to be white, pure white, and it's not. That's all inflammation, folks. That is exactly what's causing the pain in the back of the disc. And that's what we're here to remove. That inflammation and the source, which is the herniated disc right here. This is one big piece of herniation right there. Wow, look at all that. Oh my Lord. We're gonna have a lot of herniations here to clean up. So let's take some questions.
This next question coming from Michael once more on YouTube asking, do you do in-person consultations, Dr. Deuk?
I do. I do. I do in-person consultations, absolutely. I do video consultations and we do in-person. You might, up to you, but you're welcome to come to the office and see me. I'm in the office on Mondays, Wednesdays. Sometimes I'll squeeze a patient in on Tuesday, Thursday in between surgery. But the problem is you never know when I'm gonna be done with surgery. So it's kind of, you may have to wait a little bit, but I'm happy to see you in the office, yeah. Yep, we do, absolutely. We prefer the video consultations only because they're so much cleaner and simpler to do. But an in-office consultation, you might be sitting there waiting for, I don't know, an hour to see me, and then people get upset and they write nasty reviews on Google about how they had to wait so long. And so I'm just telling you, we prefer the MRI review. It's free. You don't even pay for it. We don't bill your insurance. We don't bill you. We just do it for free. It's my public service. You know, a lot of people don't realize it, but I've been a neurosurgeon 26 years, and I've made a good amount of money, and I don't feel the need to make money, but at the same time, I want to help people, and I want to help people avoid unnecessarily bad treatment for their pain. And the only way to do that is by meeting with them and looking at their individual case and seeing what's wrong and then giving them a recommendation for far better treatment. So that's what I like to do, and I can do that best on Zoom. Sometimes I need to, see the patient in the office to confirm the diagnosis, but with a physical exam, because a physical exam is so important to diagnosing the source of back and neck pain. But I can do it with 95% accuracy on Zoom. So if I give you a diagnosis on Zoom, there's a 95% accuracy to it. It's actually higher than that, but I'm being conservative. closer to about 98%. Now, here's the thing. I can diagnose any pain source on the spine, not like the knees, hips, shoulders. I'm talking about the spine. I can diagnose any spine pain source, lower back pain, neck pain, on Zoom, as long as the patient has the pain when they're doing my Zoom call. They need to know where the pain's coming from. Because I ask the patient on the Zoom call, where is your pain the worst? And then I ask them to touch their body with their fingers. And they get to do that from the comfort of their home. And I can see where they have tenderness, tender spots, like spots that are sore. That's important information. That tells me where their source of pain is. We have about 5 minutes, maybe 8 minutes, but we're close. I mean, there's some, whatever you want to do, Dr. B, you're the man in charge. So yeah, but I do see patients in person. I just think most patients are happier not having to wait in the waiting room for an hour and a half. So we encourage the telemedicine. Again, free, no charge. You don't have to pay. You do have to pay if you come to the office usually, but anyway, I don't know. I think that answers your question. Boy, look at all this herniation here. There's a lot. Look at all the scar tissue. Look at all the calcium, the gold stuff. Just, this has been going on for years. You can tell the bone spurs right here, the irregularity of the end plate. You see these bone spurs right here? I'm zapping with a laser.
Yes,
Remember,
we do.
that laser fiber is 0.5 millimeter. So 1 millimeter is the space between your fingers when you make them as small as you can, and you're looking at that space, and you can see the sky between your fingers. That's 1 millimeter. 0.5 millimeter, which is how wide this laser fiber is. This is an optical fiber, same fiber we use to transmit the internet signals through under the ocean, right? Fiber optics. It's sending laser energy along that little glass fiber, and that energy ends up coming out the end right there, and it's delivered to the tissue that I'm pointing it to, and it basically just vaporizes the tissue. And there's nothing it can't vaporize, by the way. I hear all this nonsense online about, but the laser can't remove bone spurs. Bullshit. The laser removes steel. We melt steel with this laser, all right? Not intentionally, because if I melt steel, then I got to pay for another tube, and those tubes are, they could be $1,000 just for that stupid metal tube, okay? So I try not to damage my equipment, but look, you can see there's one laser blast mark there. This is a pretty new tube. But if the laser hits the edge of the tube, it will melt the steel.
You bought that at Home Depot.
We got it at Home Depot. Huh?
If you bought a tube like that, maybe $5 at Home Depot.
Right, the tube would be $5 at Home Depot, but
It's so expensive, it's just medical.
yeah, because it's medical, so it's expensive, but I'm joking about Home Depot, by the way. Please don't report me. It's a joke. Yeah,
What you're saying is that it's always more expensive.
yeah, it is. The good news, though, is these lasers that we use are coming on the market used, and they're very good shape, and they're built like tanks. They're Israeli. They're from Israel, and the Israelis, you know, they're really good at building quality things. You know, very high quality. It used to, when I was a kid, it was Japan. You know, everything made in Japan was high quality. Everything made in Mexico, we got tons of stuff in Mexico. It was all cheap. And then it switched from Mexico to Taiwan, and then Taiwan to China throughout my lifetime. So the manufacturing base for American goods has really changed over the years. And but Japanese still make great stuff. The Israelis still make great stuff. Germany makes great stuff. Huh? Yeah, we need to make it. We need America to make great stuff. I agree, 100%. Man. Problem is the unions, and they're all got their hands in everything. So I'm not sure they're improving manufacturing, but you know, I'll stay off of that topic because I don't know enough about them. Okay, any questions?
We have a comment and a question. This comment coming from Eric on YouTube,
Hello, Eric.
saying, "Thank you for your hard work, Dr. Deuk.
You're welcome.
I've been anxiously waiting for Kim to contact me since our Zoom visit on August 16th.
Really? Kim should have contacted you already. Those guys are supposed to contact people within a couple of days. Well, I don't know who you are, and I don't want you to tell me your name because this is a public space. But, oh, hey, you know what? I can give you Kim's number.
Yeah, I have it right in front of me if you want me to put it in. Okay.
Yeah. It's 775-1862,
Yep.
321. But go ahead and post that. Give Kim a call, leave her a message. The other thing you can do is call our HR department and talk to Ron Martin at 321-775-1291. That's Ron, and tell him you haven't heard from your scheduler, Kim. And Ron will look into it and Ron will fix it. Ron's really good at that. So, yeah, talk to Ron if you'd like, and he'll get in touch with Kim. I think that would be a good move. I apologize on behalf of my staff. It's disappointing when I hear things like that. Very disappointing, especially since we have room on the schedule right now for surgery. So we could be doing your surgery today. I apologize. I feel horrible. It's a problem running a company. With me, I'm a surgeon. Most surgeons don't know how to run a company. And this is an operational issue. And I have to deal with all the operational issues. Because anytime I hire people and put them in these positions, they just don't take the job seriously. And, I always feel like it should have been done a different way. It should have been done better. The patient should have been taken care of better. And the problem is we're almost done. 3 minutes or 2 minutes, Dr. B. The problem is that I'm never satisfied the way other people operate because they don't put their heart and soul into it like I do. This is very important. This is my life's work. And, patients are everything to me. And I want my patients happy. I want them fixed. I want them satisfied. But as long as they're reasonable, obviously, which you are being reasonable on this. If you had your Zoom on the 16th, Kim should have contacted you within a couple of days. So I'm surprised because she's pretty damn good, but I would like to know what's going on. So Ron can investigate. 321-775-1291, and she will be in touch with you. Somebody will be in touch with you. If she's too busy, we'll get someone else to do it. I apologize.
We do have a question.
Yep.
This is coming from Raj on YouTube.
Hi, Raj. Welcome.
Asking, hi, doctor. You're amazing. What is the turnaround when you received the MRI review? Also, my MRI on my neck shows little compression on the sagittal view, but on my axial view, it shows multi-level. Why is this? I wanted to ask with mid-back pain,
Yeah.
can it radiate to the neck and cause neck pain, lower back pain, and muscle spasms?
Yeah, so mid-back thoracic pain cannot radiate to the neck, no. It's probably a separate issue, but I can figure it all out with a Zoom call. The turnaround time really depends on how long it takes the patient to get us the MRI scan. That's the rate limiting step 99% of the time. When people inquire, they say, how long is it going to be? They filled out the form, but they didn't get us the MRI images. We need the MRI images. So whether you send us a CD with them or you send us a portal link, 2 minutes. This is all scar tissue right here from inflammation. This is all from the annular tear, herniation right there. Usually, if you get us the MRI form today, you get us the MRI images today by sweeping them into our portal, we could do your MRI review tomorrow. That's how the turnaround time is. My staff are under sharp orders to expedite everything for people because why would we want people suffering in pain to wait? I don't. My directives to my team are you get people in right away. If they want to come in tomorrow, get them in tomorrow. We're here. We're very patient focused. That's our goal. So if there's issues, you call Ron and tell him, and we'll get them fixed. Okay? Sometimes people goof off, and that's not acceptable to me. I don't accept that. That's unprofessional. I want to know about it. They would never tell me that, but you would tell me that, and that's what's important. I wanted to show you, there's a bone spur right there. You guys see that right there? That is a bone spur, okay? Let me show you how the laser takes care of bone spurs. You can literally remove this bone spur at a half a millimeter at a time. Now you can remove scar tissue at about 1/10 of a millimeter at a time, but the bone spur we remove at about 1/2 a millimeter, okay? And there you go, okay? There you go. Now, what does removing a bone spur do? Sometimes you need to. 10 seconds, but 99% of the time you don't need to remove 99% of bone spurs. They're not doing anything to cause symptoms. So why remove them? They're only going to create bleeding and more scar tissue. Looks good, you know. Looks good. Let me just check that one corner. Any other questions? You can type them up. I will come and answer them for you personally in the conference room. And the next case today is going to be a gentleman who has herniated disc in his lower back with back pain. We're doing a 2-level DLDR, L34045. He also has piriformis syndrome, which is a torn muscle in the buttock. We're going to show you all that in just about 30 minutes from now. We'll start his surgery once we get this patient awake. We're done.
Thank you.
By the way, for those of you who've never seen the camera, the scope, this is it. You guys see this?
Yes, we do.
We call this the endoscopic rig. And it is like a big rig, you know. A big rig has a cab that has the engine, motor, and then you got the trailers. So you see we've got the actual endoscope, right, which starts here. It's attached to the camera. This is a brand new high definition camera. You got the light source right here, very bright, and it shoots light down to the tip. So if you take the source away, you don't get any light at the tip. That's what allows us to see at the base. But this is where, you know, you got irrigation here. So this, you turn this on and it comes out the end right there. And it gives you cool water around the tip of the laser. You guys see the laser right there?
Yes,
the
we
laser fiber. So the laser goes in here, comes out there. That's the tip. All right, we're done. Let's break this down, and I'm going to irrigate. I want to show you the incision for the Deuk laser disc repair. We've probably lost 10 cc's on him. He just has a lot of bony bleeding because of all that inflammation I was talking about earlier. I think 8 cc's to 10, but we'll just say 10. Irrigating. And let me show you guys, where's the tape measure? That's suction, by the way. All right, so we're going to come out with this tube. And I'm going to hold pressure for a minute because he could have a little vein that's bleeding, you know, 50-50. Half the patients have a little bleeding vein, the other half don't. But there's the tape measure to give you an idea of just how big things are. This incision is 4 millimeters. Let's see if he's got any bleeding. Not really. Yeah, it looks good. See that, Henry?
Yes, we do.
Yeah, see it? All right. So I'll just keep holding pressure just in case, just for a few minutes while Luis breaks down all the equipment. Any questions, type them up. I'm going to come there and answer them for you. I'll be there in a couple of minutes. And in the meantime, Henry, let's show people the 30 causes of back pain, because that's our next surgery. Our patient has 2 discs and a piriformis muscle, so he's got 2 causes out of 30. Actually, sorry, 3 causes, 2 discs and a piriformis. So that's 3 of the causes of back pain. You ready?
Yeah.
Copy
All right,
that.
great. Good job, everybody. Let's show them that, and I'll come answer questions. Type them up.
Copy that.
I'm Dr. R. Deuk with the Deuk Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Deuk laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Deuk plasma rhizotomy of the SI joints offered at Deuk Spine or Deuk Joint Institute. The fourth most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Deuk piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, such as the vertebral bodies, with trauma can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Deuk Majin. Thanks for joining us. Okay, great. Thanks. So Henry just showed you our new animation for Deuk Spine that we created on the 30 most common causes of chronic back pain. Now, what does chronic mean? Chronic's important. It's not acute. In medicine, we have 3 types of time periods for which diseases occur: acute, subacute, chronic. Acute means it's within a few hours to a day or two. Subacute is usually 3 days to about 2 weeks. And then chronic is anything lasting more than 2 weeks, right? So diabetes, that's a chronic disease. It just doesn't happen in, for 2 or 3 days. You got it for a lifetime. That's chronic. High blood pressure, typically the same thing. But things like, acute pain would be For example, you put your hand on the stove and you burn it, you have acute pain. Acute means it's sudden, it's new, it's going to go away usually in a few days, but that's acute pain. Well, chronic pain, which is what we're talking about, is pain that people have had, and we just say 6 weeks just to be sure we clear that 2-week mark. So if you've had back pain for 6 weeks or longer, either intermittently or constantly, then these are the causes of that back pain. And we actually know the frequency of the causes. The disc is 85%, 86%, but we call it 85 just because it's easier to remember. The facet joint is really close to 8 to 9%, but we call it 10%. So disc 85, facet 10, that's 95% of chronic back pain comes from discs and facet joints. Now, this is the primary cause, meaning you may have other causes too, like cause number 3, 4, 5, 6, and a lot of patients do. 20% of patients, 20%, 1 in 5, will have 7 causes of back pain or more. You just saw the 30 causes, pick out 7, that, you know, and there are more common than others, right? So the most common is the disc, the second is the facet, then there's the piriformis and the sacroiliac joint. Once you get those 4 causes of back pain, disc, facet, SI joint, piriformis, that's 99% of back pain, 99 of chronic back pain. That leaves 1% is fractures, tumor, infection, coccydynia, weird stuff that rarely ever happens. So the good news is 99% of chronic back pain, if you've had back pain more than 2 weeks, 99% of it can be cured with our treatments at Deuk Spine Institute. That's really what it comes down to. All right, our next patient is going to be a 2-level lumbar Deuk laser disc repair. Same problem as this guy had with a tear in the back of the disc, inflammation, pain in his back, down his leg. He's also got a piriformis muscle tear. That happens as we get older. Our muscles atrophy, we get out of shape because we're in pain. They become easy to tear because we're bending and twisting. You stretch the muscle, overstretch it, and tear it. Just like tearing a piece of steak. All right, let's go to the questions.
First question coming from Raj once more.
Hi, Raj.
YouTube, asking, I wanted to ask you how the disc heals after your laser treatment. Does the disc grow back, which you lost? Where did you find out about laser disc treatment? How did you find out about it?
Well, Raj, I stumbled upon it serendipitously, which means that I was just doing surgery for the first few times with the laser and the endoscope. This was 18 years ago. And I was treating, pinched nerves for leg pain, pinched nerve for arm pain. Same thing neurosurgeons treat, unpinching the nerve root, the nerve root, the nerve going down your arm, nerve going down your leg. And what was shocking to me was the next day when I saw the patients and checked on them, they were telling me their back pain and neck pain was gone, which I did not expect their back pain and neck pain to go away. It was not expected, it was not planned, it wasn't part of the surgery, but it was happening, and it was happening consistently. So I started to do some surgeries on smaller disc herniations that weren't pinching the nerve. But the patients had neck pain or back pain, plus they had some irritation of the nerve root. But there was no pressure on the nerve root on the MRI. And I did some of those just to see, because the patients wanted it, I did it. And guess what? Their neck and arm pain went away, their back and leg pain went away again. So then I realized that it wasn't the pressure on the nerves that was causing the pain, it was something else. And of course, then with more surgery, this is 18, 17 years ago, I'm making this realization, this discovery, that it was the tear and inflammation in the tear that we debride with the laser, and that gets rid of the pain. And that's where the problem is the tear. It's not the part sticking out pinching the nerves or spinal cord, it's the part stuck in the tear. It's called the interposed disc herniation. And that was my discovery. And the laser surgery was the way to fix it. Now, does a fusion also fix that? Yes, if you do the fusion properly, you clean out the whole disc, you're going to clean out the herniation and the tear in the back, and you can get rid of the back pain. But you're doing a fusion, and who wants a fusion? I don't. It's major surgery. It's invasive and bloody and painful and scar tissue and complications. With the laser surgery, we don't have any of that. So that's how I discovered the treatment, and it was a long time ago. We've published it. It's in books now. I mean, it's standard of care in the United States. What was the other part of the question?
Does the disc grow back? Which
yes.
where did you find out about laser disc treatment?
So remember, the disc has two parts. The disc is quite simple. I mean, some people say three parts, but the end plates above and below aren't part of the disc, not in my opinion. The disc itself is fibrous. It has a very strong fibrous wall that wraps around. It's a ring. And in the middle of this ring is jelly. So it's simple. When you get a tear in the ring, and the jelly can squeeze out through the tear and get stuck in it, that's where the pain comes from. What will grow back after my surgery is the wall. The wall will seal and heal. The jelly in the center that you lost through the herniation never grows back. That is a remnant of the notochord, which is part of your fetus. When you're a fetus, you're developing in the womb, in your mother's womb, hopefully, not your father's womb these days. Things are crazy. But when you're developing in your mother's womb, I wonder if we're going to get any hate mail for that. So when you're developing in your mother's womb as a fetus, very early on, you have something called the notochord, Notochord, which is a germ cell derivative that it has the function of inducing or using chemicals to stimulate the tissues around it, the germ cells around it, to form your bones and muscles and intestines and kidneys and heart and lungs and everything else. Okay, your brain. So the notochord is very important, but when it's done with its job in the fetus, it shrivels up and becomes the jelly in the center of your disc. There's no way to create it again, and you don't want it created again. You don't need it. People have zero disc left, and they have zero pain as long as we fix the tear in the back of the disc. All right, next question.
Next question coming from Jerome on Facebook. Asking, what are your clinical clues that the piriformis is playing a role in the patient's symptoms? I just like being here for my continuing education.
Well, Jerome, that's a really good question. Thank you for asking. What gives the piriformis away is its pain in the buttock. The buttock is the key. So if you think about where the belt is on a waist, like, you know, a man or woman's waist, below the belt is kind of the top of the buttock there. The top half of the buttock pain, either right or left, dead center, that's the piriformis. That's where it bothers you. And it's painful there, but it also can irritate the sciatic nerve and cause sciatic pain.
Next question from Charlie, once more on YouTube, asking, I probably do too much research. One source is Seattle Science Foundation. They are promoting an endoscopic approach, but never mention laser. Why? Last they discuss uniportal versus biportal.
Yeah, so Charlie, Seattle Science Foundation is great programming, but it's incredibly biased towards industry. All of those videos, they make it seem like it's a non-profit, which it is, but you know, with non-profits are weird, and people can make a lot of money in a non-profit, a lot. But you know, just pay yourself a huge salary and work for the nonprofit, and you'll see. That's Blue Cross Blue Shield is a nonprofit, by the way, but don't think for 1 minute they don't turn a profit. They do. It's just Blue Cross doesn't turn a profit, but they funnel all the profit off to their subsidiaries who make profits. Long story short, Seattle Science Foundation is where industry, the companies that make screws, rods, cages, artificial discs. I'm looking around for one of them on my table. All right, these companies, they pay for the Seattle Science Foundation lectures. They basically buy that time slot. And the Seattle Science Foundation is a place where doctors can go listen to a lecture about a topic such as artificial discs in the back, and then they broadcast it on YouTube. So it's an industry-supported activity. So, you know, the endoscopic stuff, you know, you're watching the rest of the industry just starting to get into endoscopic, which we got into 19 years ago. And here's the problem: industry moves slow. So you're seeing the very beginning of the commercialization of endoscopic spine surgery with this discussion of uniportal, biportal, no discussion of laser. That same group of people you're looking at will take 50 years to get to exactly where we are today. Maybe 100, but it will not be within 50 years. The only way they will pick up where we are, which is the best treatment there is, endoscopic, is if they copy us. And they may try to copy us. I can't tell you what they'll do, but I could just say I've been going out to these meetings just like the Seattle Science, but bigger than the Seattle Science Foundation. These are the American Association of Neurological Surgeon, the Congress of Neurological Surgeon, the Florida Neurosurgical Society, the Southern Neurosurgical Society, the AO Spine, which is held all around the world. These meetings I've gone to, North American Spine Society, NASS, and I've presented my laser surgery exactly as it is today to them. And they come and these surgeons watch it, hundreds of them. They say, this is so interesting, and then you never hear from them. Why? The answer is simple. There's no money for the surgeons in this procedure. Surgeons don't make much money. Hospitals don't make much money. The reimbursement for it is low compared to invasive surgery. Doesn't seem fair. It shouldn't be that way. In my opinion, more advanced surgery, the better surgery for the patient should be. It's very equipment intensive, very training intensive. It should be reimbursed higher, okay, but than fusions and laminectomies. But insurance companies want to keep the money, and they don't want to pay doctors and hospitals, so they decide how much they're paying. By the way, we don't. We can bill whatever we want. They'll pay us nothing. They don't give a shit, and they'll just say, sue me. And they know that to sue them, it's millions of dollars to file a lawsuit. What are you going to do? Sue them for pay millions of dollars to lawyers to sue the insurance company just to get $50,000 payment? It makes no sense. So it has to be done a certain way, and we're doing it that certain way, and hopefully we'll be successful. Next question.
Next question from Raj, once more on YouTube, asking, Doctor, what causes limited range of motion in the cervical spine? It also hurts and I feel tightness inside my neck and muscle spasms. I haven't sprained my neck, so I am confused why.
Raj, I already know the answer.
Yeah.
Raj, what you're experiencing is facet joint pain. We just showed you a video. Go back and watch it again. But you're experiencing cervical facet joint pain. We showed that video how it works. It's inflammation in your facet joints. We can fix it at Deuk Spine. Next question.
Next question from AAKK on YouTube.
AAKK. Nice having you here.
Saying, hi Dr. Deuk, in the interior approach for the cervical spine, what structures do you pass through along this colli? What are your landmarks for guidance as you approach the interior portion of the disc?
Well, AAKK, it sounds like you're about to do some spine surgery. You clear out your garage? Well, I'm joking because I don't know who you are. Maybe you're a surgeon already. But basically, if you look at the spine itself, which is deep inside the neck, right? Your spine has a front and it has a back, okay? The front and the back, very important. Anterior, posterior, and here's a lateral view. You notice during the surgery, we do a lateral view, side view, and we do a front back view, okay? So if you want to always enter the disc for my surgery in the center, right here. Now, if you're a little bit off 5 millimeters on either side, maybe even a full centimeter, you're fine. You don't want to be more than a centimeter from the midline, okay? Centimeter. So think about that. I don't think I have a ruler, do I?
Not
No.
here, unfortunately.
But a centimeter would be, you know, basically that wide right there. So you want to be within that space, because further to the side is the longus colli muscle and the sympathetic trunk, and if you damage it, you'll get a Horner syndrome in the patient. So you want to be in the midline when you enter. Now to get here, you got to go through the skin, the fat, then you got to go through the platysma muscle, you got to push the carotid artery and jugular vein and vagus nerve to the lateral position to the side, and then you want to push the trachea and esophagus medially, and you're trying to create a space between those structures, and then you get to the retropharyngeal fascia, and you get into the disc, and there's a anterior longitudinal ligament that runs down here, so you want to go through the ALL and then the annulus, anterior annulus of the disc. That's it.
Next question coming from FronJJ, FRONJJ on YouTube,
Hello, Fran JJ.
asking 6.5 years, 6.5 years after a car accident, still in pain, been up all night, neck, mid back, lower back, MRIs shows nothing apparently, although no thoracic has been done, doctors won't give me another referral. It's $3K for a private MRI for all segments of the spine. How often do you get MRIs that previously came back negative, and however you end up finding the disc issues or facet issues?
Oh, what was the name?
FronJJ.
Fran? F-R?
FRONJJ.
Fran JJ, listen to me. We can diagnose the cause of your pain, but I do need an MRI. It is there. I guarantee you it's there, and I guarantee you we can fix your pain permanently at Deuk Spine. I just need an MRI. Now, you don't have to pay $3,000 for an MRI. We do them much cheaper here. It depends on how big you are. If you're a normal built person, you'll fit in our MRI. We have a small MRI. It's open, but you'll fit. If you're heavy set, dude, and I believe you're a dude or a female, I don't know. But whatever you are, if you're big, like big boobs or big chest or big belly, you won't fit in our MRI. But we have another MRI down the street, and they'll do it for $200 a body part. Okay, 200 or 250. Point is, for $750, you can get your cervical, thoracic, and lumbar done. All right, and we can get all the answers you want. Now, our surgeries are more expensive than $3K, so hopefully you have some money or some ability to pay for treatment, because there is no treatment that's cheaper than $3K. I don't blame you not wanting to spend $1,000 on a body part for an MRI. You know, it's not an unreasonable amount to ask for, by the way. Not us, but MRIs, 20 years ago, we would get, not us, because I didn't have an MRI 20 years ago, but MRI centers would get $1,500 per body part for an MRI. And by the way, I hate to say this, the cost of the MRI has not come down in 20 years. It stayed the same. So we're buying MRIs at the same price. The cost of staffing is higher than it was 20 years ago. The cost of everything is higher, but we're getting paid by Medicare $250 per body part, which is the biggest insurer in the United States. Why? Because Medicare doesn't, insurance companies, which is what Medicare is, doesn't want patients getting MRIs. Why? Because once you get the MRI, you get a diagnosis that's fixable. Then we're going to want to go in and fix it, and that's going to cost them money. So insurance companies are doing everything they can to put the brakes on MRIs getting done, including not covering them, having high deductibles for an MRI, where the patient has to pay out of pocket for the MRI. But let me tell you something, you can't get a diagnosis without an MRI. Now, we can sometimes do it with a CAT scan, but it has to be a really good quality CAT scan. CAT scans are cheaper, but you're getting a lot of radiation with a CAT scan. You don't want that, trust me. Just get the MRI, it's much better. I would recommend you come here, let me examine you, and let's get your MRIs done here, and just plan on paying $750 US dollars. I don't know where you are now, but that's what I would recommend.
Last but not least, a question coming from Essential Advantages on YouTube, asking, my MRI showed C5-C6 stenosis and foraminal stenosis with mild multi-level facet hypertrophy. I no longer have the muscle spasms, but I have limited range of motion. Will the Deuk plasma rhizotomy cure it? And is the Deuk laser disc repair still necessary if getting the rhizotomy?
Yeah, great question. So the Deuk laser disc repair is going to fix disc symptoms coming from your herniated disc, okay? The facet Deuk plasma rhizotomy is to fix symptoms coming from your facet joint, which is in the back of the disc, back here. You see the facet joints there? I don't know if you guys can see that.
Yes,
Facet joint, disc, all right? So disc pain is 85% of pain in patients in general. Facet pain is 10% of the cause. But that said, people with disc pain do get facet pain also. So it turns out 85% of patients have disc pain, but 45% of patients have facet pain. So you probably have both. I can't tell you which you have, but I can tell you if I did a Zoom call with you what you have as the source of your pain. I just can't tell you with words. I have to see you and examine you. But generally speaking, facet pain gets worse when you turn your head from side to side, and if you're turning your head to the right and you have pain on the right inside, that is your facets on the right. If you turn your head to the left and you have pain on the left inside, that is your facets. Disc pain never gets worse with rotation, okay? So, anyway, is that it?
We do have two more questions. This first one coming
Good,
from,
you guys snuck them in, I like
Yeah.
that.
coming from Eric once more on YouTube, saying, can you talk about sports-related injuries to the spine? I grew up during an era where we used spearing, head-down tackling technique in football.
Ooh, ouch.
Yeesh.
Well, Eric, thank you for joining us, and I'll do my best. I don't know if I'm going to give you all the answers you want because I don't know everything about sports-related injuries. All I can tell you is that that type of tackling obviously is very dangerous for your spine and your brain, and the injuries to the spine are very common. When people see me for their pain in their neck or their back, they always say, how did I get this injury to my disc? The answer is always trauma. You just got to figure out where the trauma was. And was it sports injury like tackling? Was it a car accident? Was it a slip and fall? Was it just being silly as a kid, you know, jumping off the roof with your skateboard trying to land in your pool and you land on the deck? I mean, you watch Fail Army and you'll see like all kinds of stuff happening, right, that causes these injuries. But the key is any kind of sudden whipping or loading of your spine can tear your disc wall and cause that herniation to be set up so that it happens years later. If you just watch this surgery, for example, remember I showed you the blue towel with like 30 pieces of herniation? Each of those pieces of herniation, they popped out of the tear at a different time, okay? So one of them could have been that time I lifted my golf bag. The other one could have been that time I lifted that box to help my wife move, you know. Another one could have been the time the dog pulled on the chain when I was walking him and he snapped my neck, right? So any of those kind of normal activities will cause more herniations to occur when you have a tear in the back of your disc to begin with. The tear is an open door. It's letting herniations out. You don't want that. You want the herniations, if anything, to stay inside your disc, not out. Once they get through the tear, they become symptomatic, problematic for you. That's when they need surgery. So the best thing to do is come here, let me clean your tear so that it will seal and you don't get any more herniations. As far as sports injuries, they're probably the most common reason why people get damage to their spine.
And then last but not least, coming from Sammy on YouTube, asking, how much cost is the cervical operation? I am from Tunisia in North Africa.
You're from Tunisia?
Tunisia, excuse me.
Tunisia, North Africa. The cervical spine, it depends on how many discs we're fixing. Are we fixing facets? Which side, left, right? Are you going to meet with me? Thanks. So there is no one cost. We need to see you on Zoom. And the truth is, this is important. You're coming here from another country to get surgery, right? So you want to know what it costs ahead of time. You're gonna know. We will tell you exactly. But I can't just tell you what you need done by just how much does the spine surgery cost. I need to examine you. I need to see, do you have facet pain? Do you have disc pain? How many discs are causing your symptoms? I don't just give somebody a dollar amount and you show up and then you have surgery and then, oh shoot, you had other problems we should have addressed and now it's going to cost you more and you're going to be unhappy. I hate being in that situation. I don't think any patient wants to be in that situation. So we got to know the diagnosis first. before we go and give you a recommended treatment. That's very important, and it's free. You do it from Tunisia. You have a computer, you have Zoom with a camera. Sam here will set it up for you.
Hi, everyone.
That's Sam, by the way. She's amazing. But the point is, I've got to know what's wrong, and the only way I can do that is by a Zoom call and the MRI. I got to see them together, and I can figure it out. I'm going to have you do a few things. And getting back to maybe whoever's question it was about the stiffness, will the Deuk laser disc repair improve range of motion, or will the Deuk plasma rhizotomy improve range of motion? The answer is usually yes, but it's yes if you're limited by pain. So if you turn and, oh, it hurts, then of course I get rid of the pain, you're going to turn more. You're going to turn better. So more better. And so it will help you. All right. Thanks, everybody. Thanks for the questions. We will be back in 15 minutes with our 2-level lumbar Deuk laser disc repair, where I'm going to go in to the spine with a small cut in the skin. We're going to then bring that needle down right into the herniation right there. You can see it. And we're going to fix the herniations in the back. Then we're going to do the piriformis release. So you get to watch a piriformis release.